So good afternoon and welcome everyone for this wonderful panel, which give us the opportunity to talk about a very sensible subject which is rarely on the agenda, on the political and public health agenda. This is the question of how we care at the end of life. Our starting point is simple and civic. Decisions about end-of-life care require democratic debate because it is the state's responsibility to secure the conditions for a dignified death. If we believe that dignity, equity, and protection of the vulnerable are public goods, then end-of-life policy is not a private matter, it's a public issue. End-of-life sits in the crossroad of medical practice, ethics, humanity, and society. Yet, too often, the medical angle dominates policy discussions. Sorry, Libby. We talk about clinical indications, legal clauses, services capacity, which is, of course, very important, but we underplay the social gradients, the information gaps, the caregiver burden, the cultural and spiritual needs, and the democratic legitimacy of choices that concern all of us. In a public health register, we can ask, do people have the capability to live and to die according to their values? That means earlier conversations, plain language information, supports for shared decision-making. It means planning not only for clinical scenarios, but for what people want to be, who they want near, and what matters to them most. A dignified death should not depend to the postcode, income, or diagnosis. Equity requires territorial organization, home-based opinions, options, respite for caregivers, and culturally competent services. Equity is not a slogan, it's logistics. If a policy cannot be delivered fairly and close to where people live, it's not a policy, it's a slogan. Decisions at the end of life must rest on deliberation with citizens. In France, this is the raison d'être of the National Center of Palliative Care and End of Life, bringing citizens, patients, civil society, and government actors together around this sensitive and deeply human topic. And our aim is to bring the end-of-life period back into the societal domain, where it belongs, not leave it solely to clinical corridors or courtrooms. End-of-life care is a system function, palliative care, of course, and supportive care, but also primary care, hospitals, social services, volunteers, and communities. The task is to build systems, not silos, clear pathways, share tools, interoperable informations, and a workforce trained not only to treat the symptom control, but also to work on communication and ethics. And finally, what we measure signals what we value. Alongside clinical outcomes, let us track place of death versus preference, unplanned hospital use, caregivers' burden, and respite, access to advanced care planning, and experience of dignity. Data open and comparable makes policy accountable and improvement possible. Across Europe, now, countries are re-examining end-of-life frameworks. Some focus on expanding palliative and supportive care. Some other debate on assisting dying. Most are trying to build trust. Whatever the legal architecture, three questions arise. Is the information trustworthy and accessible to everyone? Are options available equitably across territories and social groups? Are decisions anchored in democratic deliberation with feedback loops to improve? If we cannot answer to yes to all three, our systems are not worthy of the people they serve. I will give the word, of course, to this great panel, and I hope that we will have a frank, sincere, and passionate discussion. Thank you.
Thank you, Giovanna. Yes, thank you, Giovanna. So, dear audience, today my name is Deepa. I'm with the European Observatory on Health Systems and Policies. We're co-hosting this session with the French National Center for Palliative and End-of-Life Care, of which Giovanna is the director. And today we want to talk about this topic because the end of life touches us all. Whether we like it or not, sooner or later, it'll become part of our own story or part of a story of somebody whom we love. And this is why we need to talk about it openly and honestly, and why the debate can't stay within the realm of the medical, why it needs to go beyond experts and professionals. And it is a fundamental societal issue and not just a medical one. So what we want to do today with this session is widen the lens with which we look at this topic. So we've designed this session as a fishbowl, and I'll explain that format to you in a minute, so that we can hear from all of you, people from all walks of society, people from all different backgrounds, discipline. We want to hear from you. And we have a panel here that is composed of not only medical voices, but also civil society and citizen voices. And the need for broader debate is underlined by the advances in medicine, the great advances in medicine. So what used to be an end-of-life period that was short and a few weeks in the hospital connected to high-tech medicines is now actually something that can go over a period of years or even a decade. It is something that we need to then look at differently because it's a fundamental shift in a way, because it's almost like a chronic disease pathway, a care pathway with all that it entails: long-term management, links to primary care, links to community care, shared decision-making, holistic approaches. And this new reality means that the perspectives of patients, of communities, of civil societies, of families is what needs to be heard. It's just as essential as the voice of doctors and of medicine. Now, at the heart of the debate lies a profound tension, which we'd like to bring out in this session today. And that is about, on the one hand, it's the view that individuals, those who are dying, should decide themselves how they die and where they die, versus the view that life is sacrosanct, that life needs to be preserved at all costs. And that's often underpinned by a society's religious, moral, ethical framework. And that tension and navigating it is something that medicine alone can't resolve, and it requires the social contract. And that is the headline topic of Gastein here today. It requires society as a whole to reflect, we all need to reflect on our deepest values: dignity, equity, justice, fairness, all of those values. And we need to ask whether, look at the title of this session, whether the end of life actually does mean the end of autonomy. And the social contract needs to reflect the response to that question. And that needs to be reflected in a country's politics and policies. And the social contract is where that fine balance is then struck between individual rights on the one hand and society's moral and ethical framework on the other hand. So on that note, we want to hear from all of you in this fishbowl session. It means that we will have one seat that it will be freed up in a second, where all of you will be able to come in and pose your question, give us your comments. So when you raise your hand, please come into the fishbowl, swim with us, we are the fish, and you can swim back out to allow for other fish to come in and be a part of this discussion. And so we hope to create a certain dynamic where we really dialogue with all of you here. We have a great panel for you here today. I'm just going to introduce them all. We have Nathalie Berriot, who is a citizen member of the governance committee of what's called the Citizen Convention on End-of-Life Care in France, which was a big large-scale public consultation in 2022-2023 on end-of-life issues, with the aim of having the results feed into the parliamentary debate on this topic. So we'll hear all about that from Natalie. We have Libby Salno, a palliative care physician, head of the Marie Curie Palliative Care Research Department at the University College London in the UK. Then we have online Francesca Mocchia. I don't know if we can have her online. Hi, Francesca, from Italy,
Hi.
Who is Deputy Secretary General of the nonprofit citizen initiative called Cittadinanzativa. And it's a well-known organization there that really advocates for citizen participation in policymaking. And finally, we have Stefania Ilinka, my WHO colleague from the regional office Regional Office for Europe, who's responsible there for long-term care. But we will start with the keynote presentation by Paola Siliti, who is a research fellow at the University of Lausanne. She's doing her PhD on end-of-life care. And before that, she was at the OECD in Paris, where she coordinated a report called "Why is Care at the End of Life Not Matching People's Preferences?" So maybe you have an answer to us in your presentation. Over to you, Paola.
Thank you so much. Thank you for the invitation, and thanks for the introduction. It's quite an ambitious task to answer that question. I will have 10 minutes to basically answer the question and kind of give an idea of where we stand in Europe in terms of end-of-life care. So that's ambitious to say the least. So what I'll try to do is I'll try to talk about some of the key challenges that we are facing in Europe when it comes to end-of-life care. And then I have a last slide where I would like to open the discussion on what's the way forward. I think that's the perfect setting to open the discussion and to have an exchange on that. So if you are here, I probably don't need to show you much data information on the aging trend of our population in Europe, on the growing burden of chronic conditions. We also heard it from our colleagues yesterday in the value of care session. So what I wanted to show you here today is how does that translate in terms of end-of-life care needs and demand in the coming years. And here I have some I realize it might be a bit too small, but I have this slide where you can see basically the projection, the OECD projection on the need for end-of-life care up until 2050. And in 2019, when these projections were calculated, there were around 10 million people who were dying across OECD countries, and it was estimated that around 7 million people would have benefited from end-of-life care at that point. And this figure is expected to grow up to 10 million people needing end-of-life care in 2050. But here what I really want to stress and to highlight is that here we are only looking at people who are dying, who need end-of-life care for themselves. What we are not seeing in this graph is all the people who are caring for a loved one at the end of their life, who might need bereavement care after the end of life, after the death of their loved one. So this is already a quite striking figure, which can even double or be multiplied if we consider bereavement care within it. So it's quite a striking trend. So we see that the need for end-of-life care is growing, but we also know that end-of-life care is a range of different services. So when we talk about end-of-life care, we talk about all the different care options that people have when they reach the end of their life. And we know that these options are expanding over time. We have more and more discussion around assisted dying across European countries and worldwide. And what I wanted to show you here on the right-hand side of the slide is that in 2019, there were 200 million people worldwide who were living in jurisdictions where assisted dying was possible. This figure is obviously higher today. I think we are around 3 million people at least, who are people who are living in countries where assisted dying is a possible option. And when we talk about assisted dying, I think it's always important to kind of remind that there are differences internationally. There are differences in terminology, in the way assisted dying is performed. So in this presentation, I will talk about, and in the discussion we will have, I will talk about assisted dying, referring to it as an umbrella term, so including all the different legal sanctioned practices that are intended to hasten death. And this includes both euthanasia, where there is a physician that performs assisted dying, or self-administered assisted dying, or also called assisted suicide in some countries, where it's basically the person themselves that is self-administering the medication. And as I was saying, this is not the only difference we have across countries. Assisted dying varies in terms of eligibility criteria, so who can get access to it, the modalities, so whether it's self-administered or physician-administered or both in some cases, the providers, whether it's within the healthcare system or whether it's more of a civil model, and the medication also varies widely across countries. So we have a widening range of options at the end of life, but we also have inequalities across countries in Europe. So the way countries are developing end-of-life care is quite unequal, kind of at different speeds, we could say, across Europe. And we can see here on the slide some information on the health policies on end-of-life care, on palliative care in Europe. And we see, again, maybe it's too small, I didn't consider the size of the room. But around half of European countries have some policies on end-of-life care that are not updated, that have not been updated in the last 5 years. And on the right-hand side, when we move from policies to practice, what we see on the map is that the specialized palliative care services vary widely across countries. So the availability of palliative care services vary widely across Europe. So here we see differences across countries, but when we zoom in within a country, within countries, what we see is that there are inequalities even within the same country. So here we pull data from 28 European countries. This is a recent analysis published on the Lancet Global Health. And here, together with my team, we analyzed the probability of people to receive palliative care in the last 4 weeks of their life. And we analyzed it for people who have financial difficulty and for people without financial difficulty. What we see is that people with financial difficulty seems to be less likely to receive palliative care at the end of their life. And what is even more worrying is that the gap seems to be widening since the COVID-19 pandemic. So I think it's important to reflect on that. What happens in times of crisis? We've been talking a lot about crisis these days, what we are already living, what we are going to live in Europe. What happens when we have a crisis that hits health systems? People who pay the biggest price are people that are in more vulnerable situations. And in this slide, in the next slide, I really don't expect you to be able to read this. It's just for you to see that we have basically performed the same analysis as before, but looking at all the different types of care that people can receive at the end of their life. End-of-life care is not just palliative care, so we see that the same pattern is replicated in almost all different types of care that people receive in the last year of life. And one additional finding that is you can probably see from this slide is that most older people across Europe receive hospital care at the end of their life. Other types of care, home care, hospice care, nursing home care, are much less available to people at the end of their life. So this really brings me into my next point, which is what happens for those people who are accessing end-of-life care. So we know that only around 40% of people who need it actually receive palliative care. What happens when we look at that 40%? And here we know from the literature, we also heard it yesterday in the value of care session, that people usually prefer to die at home or at least in the place where they are living. What we see in the data, though, is that the care that people want and the care that people wish for is not really in line with what they are actually receiving. So most people across OECD countries, including European countries, are still dying at the hospital overwhelmingly. So why is that? What is the reason why there is this mismatch? And I think that's one of the things we could probably discuss about today. Here I try to give some initial ideas, and I think one of the main answers is to be found in the way end-of-life care is funded. If we look at public funding for end-of-life care, it is very geared towards hospitals. This obviously reflects the availability of services. Services at home or in other settings are much less available compared to services at the hospital for the end-of-life care. There might be also cultural preferences, cultural differences that lie behind the type of care that people receive at the end of life. And then there is also the question that I think will be discussed widely today, the citizens' involvement in decision-making and in research. This is an issue in all types of policies, but this is a particular issue at the end of life, how to involve patients, people in decision-making at the end of life. So patients' associations for end-of-life care are obviously very few. It's very hard to have patients' representatives. So what is important is really to have citizens' involvement at the end of life, for end-of-life care. So we will discuss about it later. But here I wanted just to conclude on what's the way forward. And this is really just to open the discussion. I put here some of the key points that I think could be the way forward for a better end-of-life care. And I think 3 key takeaways from the presentation are really that end-of-life care needs are growing, that there are inequalities across countries, but also within countries, and that the care that people are receiving do not always match what people actually wish. So we go back to this idea of what's people's choice at the end of life. So here are just a few ideas: expanding access to care without taking into consideration and focusing on vulnerable and disadvantaged groups, addressing the cost, the social determinants of health, and the inequalities do not arise at the end of life. They exist and they build up during the life course. So it's important to take that into consideration. So as addressing the social determinants of health early on, ensuring the fair distribution of public funding across all settings of care, investing in community and home-based care models, and also have research and evidence on that, and investing in social participation platforms that we will talk about later. So it was a bit of a run, but thanks for bearing with me, hopefully, and I'm looking forward to the discussion. Over to you.
Thank you, Paola. So we really see that there's this disconnect between what people want out of their end-of-life care and their needs and what happens somehow in reality. And you also ended by saying we need to discuss and dialogue more with people and patients and citizens. And so I turn to you, Natalie, because the convention, the Citizen Convention, it's unique, it's important. We need more of such initiatives of reaching out to people and civil society and listening to what the needs are for end-of-life care. So tell us a little bit about that experience. How did it go? It was very high profile with President Macron backing it. And what were the main results and the different stakeholder views?
Okay. Thank you. Thank you for the invitation, and thank you for my first intervention in English in a Congress. So you'll get my lovely French accent. Thank you. Well, is the end-of-life support framework adapted to the different situation encountered, or should changes be introduced? This is the question Elizabeth Borne, the then Prime Minister, asked us for whom the convention was established. How did the convention go? The context, the Citizen Convention on the End of Life brought together 184 randomly selected citizens in 22-23, illustrating the diversity of French society: gender, age, urban, rural, educational level, socioeconomic status, or regions. We had access to quality scientific documentation produced by the National Center for Palliative and End-of-Life Care. We organized hearings with about 60 French and international experts in various fields like legal, medical, patients association, religious and philosophical bodies. We self-organized visits to palliative care services and other health services like cancer, emergency, neonatology, etc., etc. The final report was adopted by a vote of 92% in favor, 5% abstention, and 3% against. And it was submitted to President Emmanuel Macron in April 23. One last session was held on April 24, where the French president and his government came to report on what they were going to do with our work. This corresponding to the launch of the bill on the end of life, which incorporated many of our recommendations. Unfortunately, on 9th June 24, you probably know that the National Assembly was the National Assembly dissolution killed the legislative process at the Parliament. A friend of mine, Loïc Rézibois, who was waiting for this law to escape a painful death, said that the dissolution was the kiss of death. My friend is dead. Today, in 24, 116 French people went to Belgium to receive medical assistance in dying in 24. We don't know how many went to Switzerland. This is also for the context. With the new already ex-Prime Minister Bayrou, 2 bills instead of 1 were submitted to the Parliament. But with the political crisis we are going through, the question is currently out of debate, but it will hopefully be picked up again at some point. Reactions of the stakeholders, policymakers and health professionals. Reaction before and during the convention. Suspicion and instrumentalization by the president. Suspicion, the idea was, what can possibly come out of a group of people who know nothing about the subject? And above all, drawn at random. Wow. Even in the governance committee of the convention, some members thought it was going to be a waste of time. Instrumentalization by the president, where we're going to be the president spokesperson, sorry, but it didn't happen. Why? As everybody knows, I don't know if you know, but in France we know, no one knows what Emmanuel Macron has in mind, not even him. But at the end, we got respect and cooperation with policymakers. Respect was the minimum, I should say, because we work and everybody saw our report. Cooperation with policymakers means hearing, we were asking to go to the Senate, the National Assembly. We met the health ministers who were invited in the Congress and so on. Key issues on the French end life or debate. You should ask, what did we say? What does this report say? 90-70% of the citizen convention felt that the current French end-of-life support framework needs to be improved, and 82% that it is not adapted to the different situation encountered. On the specific point, assisted dying, 76% were in favor, 23 against this proposition. The shared conviction, and this is really important, is of the convention member, is to strengthen and improve end-of-life support, because to date there is unequal access and a lack of satisfactory solutions for certain end-of-life situations. Several collective proposals were adopted by over 80%, such as respecting the patient's choice and wishes, providing information to the general public, strengthening training for healthcare professionals, ensuring the necessary budgets for end-of-life support, developing home care, ensuring access to palliative care for all over the country, ensuring equal access, improving the organization of the end-of-life care pathway, intensifying research and development efforts to better manage suffering and develop future remedies. In this report, and maybe this is the key word sentence, in this report, 70% of convention members did not oppose, I repeat, did not oppose palliative care and assisted dying, but viewed them as a continuum of care. A position that, this position that has remained stable for almost 40 years in France, because for almost 40 years, surveys, focus group, and even previous citizen convention on the subject said that. The main point of contention was, of course, the issue of assisted dying, which was the central topic of the citizen convention. But probably there will be a question about that. Thank you.
Okay. Thank you, Natalie. So we really see the power of people's voice in pronouncing themselves on this topic. Also, you give them the chance to become experts in a way, access to expertise. You give them the time, the protected space to really reflect on the topic. That that what comes out are really well-reflected reports that can feed into policy processes. So I'd like to now open the floor for questions, comments. Anybody would like to come in? I see a hand here already. Please come in, take a seat here. Can you please state your name and your affiliation and your question or comment? Thank you.
Okay, thank you. Oh, this is nice. Magda Rosenmüller, Jesse Business School. I love the gender imbalance of this panel. Because it's for the informal caretaker are mainly female, so that's good. I have one point that I would like to raise rather the time before the death or chosen end of palliative care, which is then, but how can we make that time better? We are in a project, the first that it's supported by the European Commission on use of psychedelics for palliative care. And the results, so it's about a year ago to put the clinical trial. We have heard how difficult that is, particularly in this area. That about psychedelics, I can talk long about all the problems around it. But the message I would give is like the results are astonishing. That people that really have difficulties in accepting that could be cancer or could be a disease like COPD or Parkinson or like end stadium of that they find peace, and that I think it's a very important. So psychedelics is used for drug-resistant depression, and so this is helping the people of getting kind of a spiritual experience that helps them to better cope. And I think something that you said earlier, I think was really interesting is like the caretaker. I already referred to them. With that, it's much more easy. It's much easier for them when the patient or when the person at the end of life is in peace. So it eases not only his or her life, but also of all around. So that was my comment. I don't know if anyone wants to comment on that. Thank you.
Okay. Thank you. Yes, I think what this really raises is the issue of something that patients and people want. For example, psychedelics, where perhaps the legislation isn't there, where a lot of there's a lot of clinician hesitation and reluctance. But how do we marry people's human and spiritual needs on the one hand with medical, clinical realities? I'm looking at you, Libby, to talk to us about that.
Yeah, I think the kind of sudden explosion of the use of psychedelics, psilocybin, is really exciting, and it's got.
We do it together with the European Association of Palliative Care.
Yeah.
So the
EAPC are doing lots of good work, and I think it gets to the heart. Whether it's psilocybin, whether it's really kind of focused counselling one-on-one, whether it's getting to trauma-informed care to allow people to uncover actually kind of what the hidden trauma that's now coming up, and I see that a lot in my clinical care. So it's making sure that we've got really effective ways of managing this, because one of the challenges is that we will all enter this time in our lives, and mortality is a huge challenge to our existential being, and it's something that healthcare is really not well set up. We are in a society of culture of cure, and that's what I've heard so much around for good reason. We want to reduce avoidable mortality. But what we have to recognise is that there's unavoidable mortality that is our state, and that can be very challenging. It's what arts, religion, poetry, music is often around, helping us understand what that means. But palliative care is one response to that, and a very good response to normalising these issues. But what's a challenge is that it can't, these are difficult times. They're sad, they're distressing, and what often healthcare in the broader sense doesn't have the time to unpick, to understand that. And so ideas like psilocybin, the palliative care world allows a real time to say these are difficult issues, but they need to be understood. And crucially, they can be managed. They are not too big. They're not too difficult. But if you try to ignore them, give them no space within a healthcare setting, within consultations, then they do become bigger and harder to manage.
But
so
it needs good mental care, and it needs it needs good mental access to mental care or support, because it is not the one, you don't take one pill. It's a session, it's preparation, it's post-preparation. So it is a health system issue, and here it's like so important, as you said, that we facilitate the access to these type of treatments. Thank you.
Thank you. Julia, is there a question online that is related to this? Please come and swim with us and tell us what they're saying in the chat box.
Thanks, Deepa. My name's Julia Zimmerman. I'm a younger Steiner, and I'm manning the news desk for this Fishbowl. So that means I am giving voice to some of the comments and questions that we receive from the online community. So this is a reminder to the online community to please do post. We've had some really interesting questions and interventions, and I'm looking forward to receiving many more. So I think one of the questions that has come up that really fits the previous intervention is the question, well, why is it that what we are doing currently is so different to what we want?
Who would like to take that question? Paula, I see you nodding.
I mean, it was partly what I was trying to talk about during the presentation. Why is it? That's a great question to ask ourselves. We know we have the evidence that this is not matching what people want. But as I was saying, I think there are several things, but I think the first thing relies really on the funding. And I know that's like maybe health system focus, but that does make a difference. People cannot access care at home because care is not available for them at home in many places in Europe today. So how can we improve access for care where people want? Well, we shift some of the funding. It's not necessarily funding more, but maybe funding better. So funding something that is more efficient and more in line with what people want. But then again, I think really I want to stress again the importance of really recognizing what people want and involving them in decision making. Like, how can we make sure that there is more alignment? We need to involve people to know what they want. Otherwise, we are in two different silos. There are people who make policies that are far away from the people who actually live the experience. So I think I'm having a Astis there to support the next intervention.
No, I want to jump on that because it's also about what we define as palliative care. And you threw a lot of concepts from assisted dying, which is not palliative care, end of life, which is not palliative care, but it's also what we mean, right? I talked yesterday about palliation and end of life care being part of the long-term care journey and of the long-term care pathway, because the way we tend to look at it is that 100% of people need end-of-life support. That doesn't mean they need palliation. That doesn't mean they need medical symptom management. It doesn't mean they need opioids. It doesn't mean they need access to assisted dying. But everyone goes through this process. So at the very least, a basic emotional support, access to information, access to bereavement care and counseling for caregivers, for care partners, should be part of any care pathway. And then for specific populations, we can do better at bringing care where people need it, wherever it is people die. It tends to be hospitals, unfortunately. We can change that. But I thought it was quite scary to see how many people die in nursing homes where there is virtually no palliative care capacity, and they would need it. So it would be really fantastic to think about how we spread the capacity that exists in very specialized settings, as you said, and distribute it to where people actually die every day.
Yeah, so it's really about bringing together what people want and what they express that they want, and with the politics and the policies, and also the role, as you say, of talking to citizens and talking to people. And an important bridge role there is played by civil society, by NGOs. So I'll turn to our online speaker on that topic, to Francesca, if she could come on the screen. As the Deputy Secretary General of Cittadinanzativa, you promote civic you are a civic movement, and you promote citizens' rights and active citizenship. And can you tell us, in Italy, how NGOs can play a key bridge role between people, policymakers, especially on this very sensitive topic of end-of-life care. Your organization has been really key and central to that in Italy. Over to you, Francesca.
Okay. Good afternoon. Thank you for the opportunity to speak at this conference. Thank you for your question. I'll do my best to answer it. In Italy, civil society organizations like Cittadinanza Attiva have played a key role in securing certain rights related to the end-of-life period. These include the right to pain therapy and palliative care, the right to informed consent, and the right to make advanced decisions about one's care. This progress has not come easily. Italian culture remains deeply influenced by the Roman Catholic Church, which often frames end-of-life issues within a specific moral and religious framework. From this perspective, decisions about death and dying should be guided by a moral ethic rather than by the wishes of individuals or their families. As a result, some members of the Catholic Church have consistently opposed assisted suicide and euthanasia, arguing that the priority should be palliative care, alleviation of suffering, and protecting human life. Similarly, some conservative political parties invoke moral, ethical, or sanctity of life arguments, stressing potential abuses. However, there has been growing support from civil society, right-based organizations, and segments of the general public for greater autonomy in end-of-life decisions. This includes support for living wills, the right to refuse treatment, and assisted suicide under sick conditions. It was civil society's voice and pressure that resulted in a law established in 2010, which gives the right to pain therapy and palliative care. Civil society organizations were central to this achievement. They collected patient reports and complaints, monitored the quality of services, raised awareness among healthcare professionals and administrators, entered into dialogue with the Ministry of Health, and participated in institutional forums. These actions garnered support for the law when it finally passed. Another significant contribution came in 2017 when civil society partnered with health professionals to help pass a law which gave the right to be adequately informed before receiving any medical treatment and the right to provide consent for treatment. An important aspect of this law being the ability to also change one's mind and refuse any proposed treatment. For the first time, this legislation introduced the concept of the Advanced Healthcare Directive in Italy. This gives individuals the legal means to express their preferences for medical care in advance, particularly in situations where they might later be unable to make decisions autonomously. In Italy, civil society has played an important role in advancing end-of-life rights, pushing for laws that prioritize patient autonomy, informed consent, and access to palliative care. While important progress has been made, strong cultural and political differences mean the debate over end-of-life choices is still ongoing. I hope this debate will contribute to the passage of fair laws in my country. And thank you.
Okay, thank you. Thank you, Francesca. I think the Italian case really shows us that tension that I was talking about earlier between sort of individual rights and the view that the person who's dying should choose how they die, and a strong moral and religious framework that a society ultimately buys into. But it also, I think, shows us some of the really practical issues that that civil society can really help advance, where real progress can be made. Things like living wills, the right to pain management, the right to say no to certain types of care, and to decide in advance, the right to decide through advanced healthcare directives, what you want during your end of life. And so the question that I have then is, how is all of this then integrated into a care pathway and into the patient pathway, really? And I'm looking at you, Stefania, because WHO calls on end-of-life care and palliation to be a universal part of the care journey and focused on not only patients, but also caregivers. And you often write about, or WHO has written in its reports, that we need to assure a good death. What does that mean?
Yeah, it's a good question. To the question how it's integrated in current care pathways, the answer is poorly, and that's easy to say. The question that we're still negotiating at every level of care is exactly what we mean by quality of life and quality of death, and how do we design care services that allow to adapt to the preferences of each individual, each society, each care user, and their care partners or their family. Under the UN Decade of Healthy Aging, we have taken on the challenge to monitor quality of life and quality of death, and we're very much struggling with how we define indicators and what it might mean to monitor quality of death in different societies. There are a few principles that we've identified as essential, but we're quite a long way from actually coming down to indicators. You've mentioned a few of them: autonomy and control, and this might reside with the individual, might reside, depending on the culture, with care professionals more than with the individual themselves or with their family and community, rather than, again, an individualistic approach. Symptom and medical management of pain is an important aspect of a good death, but equally important is the psychological and emotional support, whatever this might mean for any individual. There's the aspect of access to information and communication, being aware, having the right information to face the reality of your own death. There's the aspect of quality and accessibility of the care each individual considers necessary for their own well-being. There's a personal aspect of feeling a need of a sense of legacy and closure. And finally, there's an aspect that has to do with control over one's circumstances. Ideally, we would see that there is end-of-life support and palliative care, as I said, wherever people die across settings, irrespective of the condition that people die with or from. And as difficult as it is to confront this reality, irrespective where people are in the life course. We need neonatal palliative care, we need pediatric palliative care just as much as we need geriatric palliative care.
Thank you. Yes, go ahead.
I think it's such a good point that Stefania's made, because the WHO and their current inclusion of death and dying as part of the life course is really quite radical, which seems ironic to say that we're kind of including death and dying on a life course approach is quite a radical act. But actually, if we look at health policies, public health strategies, discussion on any range of life-limiting conditions, death and dying has always been omitted. So it makes it really hard, as Giovanna said at the beginning, if we don't value, if we can't see how to measure it, then it appears that we don't value it as a society or as a set of policy documents. So the kind of advocacy has been very much to get death and dying just recognised not as additional extra services and extra care, but just as part of a continuum of good care from birth to death. And actually, the prevalent narratives have really been around from birth to successful ageing for as long as that is. And so how we begin to put that in a healthy life course approach, and actually palliative care in itself is not expensive. You know, that often if you look at good models of care, people wish to be at home. It's community care. As Paula said, the infrastructure isn't there, so there's probably some expense there, but actually it's home-based care from a multidisciplinary team rather than in hospital with high tech. Often it's using advanced care plans to say, I don't want that. So by rolling out palliative care, incorporating it into a life course approach, into all, you know, you talk about health in all, I think, you know, death in all, it is part of life and part of our health appropriate kind of care. And the WHO has really, in the past recent years, have really put it into all of its other policies, which is the first big step, because if it isn't there, you can't write a policy, you can't write indicators for it, you can't have public narratives, and you can't then allow people to have death that they wish to have.
Okay, so death in all policies. Yes, please, please come into the Fishbowl, if you can state your name and affiliation.
Yes, okay. And maybe one of you is brave enough to come and tell us what they think good dying means.
Yes.
Okay, thank you. I need to comment first on the title, but first react to your
name and affiliation first.
Okay, just to explain my reaction. I'm Alexander Đakula. I'm from Zagreb, Croatia, and I'm co-author of the first national strategy on palliative care. This is not only the first in Croatia, but it's maybe, I think, first in the world that have incorporated palliative care as integral part of healthcare in a way that it's obligatory in primary healthcare and in secondary healthcare, including acute hospitals. We oblige hospitals to have at least 1%, that means few beds, to be palliative care. Why? Not to develop some independent program in hospitals for palliative care, but to force professionals and management to recognize need, because all the patients who need palliative care, maybe 100%, time to time need episode when they will go to acute care hospital, and when they underwent some procedure or they spend a few days there, they need to be treated properly as a palliative care patient. So we have integrated palliative care into the healthcare system fully covered, financed by the palliative care, by the public financing as a palliative care, and also it's integrated in the national strategies with social welfare. So this was a big fight. It's not going extremely well, but it's going very well. Why? Because we decide to use existing resources. So instead investing in new capacities, we introduced coordinators for palliative care in primary health care. And they start to use existing resources, they are nurses, and now we have huge impact by them to the professionals, but also to the community. Why we succeeded? Because we recognize two problems that we have in this title too. This is the paradigms. Still, dominant paradigms are that palliative care starts when active care ends. And in many people's minds and positions, it's something what's very clear. It's extremely wrong. So from the perspective of organization, it's extremely important to remove this paradigm. Palliative care and active care are complementary and parallel. There is no end and beginning. They last and together. This is the first big problem. If you want to do anything, you need to remove this old paradigm and take new one, complementary and parallel. This is the first. The second is a huge and very interesting and in some ways sad problem and paradigm. Because of historical development of palliative care, it is recognized as a humanitarian, voluntary, out of the system activities to support dying people. Completely wrong. Change this paradigm immediately, otherwise you'll have a problem. What is a huge problem? If you keep this paradigm, then civil society will do a great job, but on the other side, you will do huge damage. Because we promote idea, civil society will provide service, we will do that instead of state. No. Remove this. Palliative care have to be obligatory program in public financed by public sources and the system, whatever. And that's civil society could advocate and promote and be supplementary to the existing services. So the first step is to change paradigm. The first, as I said, they are complementary, active care and palliative care are parallel and complementary. And second, it's not parallel system, not humanitarian system, not voluntary. That could be obligatory, publicly financed system. That's why in this, and also in France, you have end of life and palliative care. So that means different. Palliative care is something that lasts.
Thank you. So I think that really shows this paradigm shift where we said at the beginning, this is no longer a few weeks at the end of somebody's life with, connected to some high-tech machines in a hospital. This is something that is a longer-term, almost a chronic disease approach is what we need. We need to think of it as a care pathway. Thank you so much. Nick, I saw a hand up. Please come into the fishbowl.
Thank you.
Thank you. Nick Fahey, RAND Europe, and also appropriately in this context, advisor to the European Observatory. And I should preface this by saying I think this is a really important discussion. And I think the orientation that you, for example, what you said about the radical character of what the WHO is saying here, I think this is such an important contribution to a really important set of subjects. And I do not wish to be awkward. But we talking about the social contract, we are, and it builds slightly on the contribution of the previous speaker. We are in a time when we do not rely on universal public support for public institutions, if I can put it that way, or a total lack of cynicism about the motives of those in power. And we have seen in some instances that when we tie, I'm thinking of the Liverpool Care Pathway, when we link palliative care to elements of the role of the state, to the power of the medical profession, to funding streams, not everyone sees that as a completely neutral act. And so I guess my question is how, within that context of a slightly contested social contract in this space within Europe, knowing both the importance of these issues but also the sensitivity of them, how do we best have these conversations in ways that ensure that they remain focused on all the elements of, as you said, end of life, end of autonomy, of sustaining the values of effective end-of-life care and the role of palliative care within that, and not, as also the speaker from Citadin Activa said, link them into political discussions, role of the state, ideological discussions, because that way I fear this becomes seen sometimes as a sort of a slightly instrumentalized process. As I say, I don't wish to be awkward, but...
Yeah. I can do a quick response. So I would say I totally hear the challenges that you bring. I think it's right for us not to romanticize this and actually really situate it in the current geopolitical context, which is what this Gaston is all around. But I would say, to kind of continue your point, actually we're already in a point where the state are controlling death and controlling experiences through consumerism, through a lack of patient voice, a lack of patient decision-making, a lack of other options. So at the moment, I'd say we're already in that very bad situation where people are having deaths they wish to have in hospitals and not having the care they wish, having no voice. And so the new vision of palliative care, of end-of-life care, and of broader kind of care in these times, that is a new vision of much more patient, person, citizen-led care. So I'd say we're already almost in that worst nightmare of instrumentalization, of control of what you can, what you can't have. And actually, if we then looked at a much more open one where people have options, have the right information, have choice, then that's where we lead somewhere different. And I think that would involve whether the state is enabling those options, actually a stepping back of the state, allowing people having more freedom at the end of life.
There is one paradox. And there is one paradox. Optimal palliative care is cheaper than basic medical care. So it's paradox. We can save money treating the better palliative care patients.
Okay. Thank you. So you mentioned instrumentalization, Nick. So I'd like to ask Giovanna maybe to comment on that, given the risk of instrumentalization with the high-level backing of the Citizen Convention.
Yes, of course. And Natalie said precisely what was the risk, the major risk about instrumentalization, the speaker of the president and so on. This is quite normal. This is a political debate also. It's a democratic debate. So it's quite normal. But what I think it's important to underline is if we can let this object, this issue, a sort of object of manipulation, is also because there's a huge lack of knowledge about dying, death, about palliative care, but also other palliative, as Stefania said. I mean, today, in our countries, developed countries, we think that death will be, we hope that death will be arrive the farthest as possible, but it's a sort of taboo to talk about. And the less we know, the more we are supposed, we risk to be influenced by others. So what I think, which is very important, I think that Libby will agree with me, it's the culture of palliative and death. It's the death literacy. It's teaching people, educate people, and I talk about civil society, but also health practitioners, health professionals, to think about death no more like a sort of failure, but as something which is a natural objective. So this is a very, very important point because because participation, because information, because deciding for ourselves needs to be conscious about the question, about the issues, about the conditions, and probably to be in capacity of remove all influence, even politically. So, well, this is my my point.
That's a hugely important point, that we need to make the topic of death no longer a taboo, that we need to talk about it the way we are talking about it here today. I'm looking in the room. Who wants to come into the fishbowl, please? Dimi.
Sure, thank you. Yes, I'm Dimi. I work with the Observatory. I wanted to say mostly very similar to what you said. I think it's important for me to point out, I've been working with a group with the Siana Network, talking to experts in different countries about end-of-life care and what is important and what we should be striving for. And I think let's see, the leitmotif that we see going through is, one, we don't talk about it enough, we don't talk about death enough, we don't talk about it in society. We have tools like last aid courses or things like that can maybe help us. We don't talk about it with the professionals enough. They see it as a failure if they can't offer an alternative that is curative somehow, so that's a different paradigm. From the health system perspective, and that's important, of course, to us at the Observatory, but in particular, the financing needs to be aligned. One of the main insights that we have is this important quote, and maybe you've talked about this a lot already, but I missed the first part of the session, apologies, the what matters to you question. Which won't be, because when you ask me what is a good death, maybe I will answer you, but it will be different for me than it will be for you. So I think the main point is that we build into the system this dimension of what matters to you, and then that the system is flexible enough to accommodate that for different people. I don't think we can be dogmatic about it.
Thank you. So that goes back to asking people and citizens what they want out of dying. I see Julia has her hand up. There must be a lot of interventions online, and then we'll go to the hand just behind.
There are a lot of interventions online, and thank you to anyone online posting. It's very interesting to read your reflections. So I think the one that really speaks to the last couple of interventions is the question, we all are patients that will face these questions as well. We all have families where we will be facing these questions. What are some means to support patients and families to feel more empowered to access and organize care in a timely manner? And I think the reflection we heard earlier, where it's not just a short-term thing, but a whole process, I think really links into this.
Would you like to talk about the caregiver?
Yeah, but I hope people will jump in and help me out. Maybe if someone here works on dementia care, I think the gold standard in the dementia care pathway, for example, is to receive information about end-of-life care and palliation post-diagnosis. That is the timeline of trying to engage with the idea that this is a terminal condition, this is a life-threatening condition, and that it affects, as I say, the person with the condition as well as their family, and together they go through a journey that they negotiate. Advanced care directives was mentioned before. It's not possible everywhere, it's not really enforceable everywhere, but how many of you have had a discussion with close family about what it is you wish in the case of your death? Which hopefully is 50 years from now, but it might not be. So it's a very personal, very individual process. It includes, I think Libby can talk more about this, truly a multidisciplinary team, because it has this aspect of emotional support, of spiritual support, of connection of medical support, and of course the nursing, the care, the relational aspect, being part of a group, feeling supported, being in company and in the place of your choosing. I really hope others can pitch in here, because it feels like a really important thing.
Please state your name and affiliation.
Yes, I'm Valentina Stramiello. I'm the Interim Executive Director for the European Patients Forum. And I found the conversation really interesting, and we need to talk more about this. We always try to promote and advocate for treatments and potentially curative treatments, but we should not neglect that we need to protect also people's right to death and to choose the way they want to die. Besides the fact that I represent all European patients, I'm Italian as well. And I can tell you, and I have an anecdotal story I can share. We can talk about how, but even before we talk how this should be handled, it's about whether it can be handled. In Italy, it's illegal to get assisted dying. It's illegal. There were people who were sent to court. And so even before we talk about how it can be done, it's whether it can be done. We need to talk about how we can advocate at the parliament level with politicians to promote the legislation, as the lady from Cittadinanza Attiva was mentioning. So, I mean, I think it's a question of maturity of healthcare systems. I live in Belgium, and I do know that in Belgium, the system is much more advanced. But it's not the case everywhere. So it's a cultural, legal, religious matter. And this despite the fact that often individuals have their own views. And it's true that what we can do as a civil society is to raise awareness, but raise awareness to find a workaround, because that's the reality. In Italy, you may find a workaround. You may find a nurse or a doctor who's willing to support you and assist your death. But it's not considered legal. It's done in silence. That's the reality. So I think we need to do a step back and look at the legal elements, the legal aspects of the discussion.
Yes, so this topic of assisted dying, of course, it's going through many parliaments at the moment, and it was also discussed in the Citizen Convention. I think the Citizen Convention was very clear that they were in favor of it, but there were some clear reasons also that were spelled out. Can you tell us about that, Natalie?
Yes, of course. Where I find my paper. Well, in fine, we've got 5 main arguments in favor of assisted dying. And I get the same definition of Paola for assisted dying. The first was that the current support framework does not address certain situations of suffering, such as refractory suffering, both physical and psychological, to take just one example. The second argument is assisted suicide, assisted dying does not address all the situation of people at the end of their life. And this is really important, because when you speak in French with people who are against, they say, okay, if the law is going to be voted, everybody is going to, all doctors will say, so you want to assisted dying or what? And it's not the situation, of course. I shall tell you that in France, about 3 or 5% of death, dying and death, could be concerned, thank you, by this law, for instance. And even with the development of palliative care, there will still be those few people whose suffering is unbearable and who wish to be relieved, even if palliative care is everywhere. Sorry. The third argument about why we are in favor, assisted dying addresses the limitation of deep and continuous sedation until death. I don't know if you know what it is in France. You know probably, I'm sorry. Which can only be applied in France for a short period at the end of life, because the medications used have a limited effect. However, some agonies last several days or even more than a week, some weeks. These are the patients, the French Council of State. The French Council of State in France is the French court which says the law, as we say, is referring to these patients when it writes that they never finish dying. They never finish dying. Assisted dying reduces this time of agony, providing relief to those who have chosen it. The patient itself, of course, but the family and, in certain situations, caregivers, professional, health professional. The fourth argument for assisted dying puts an end to what you said, to hypocritical, I don't know if it's okay, but you got the idea, situations because passive or illegal euthanasia exists in France. Implementing it means bringing reality into law, avoiding hypocrisy, and protecting the medical profession. And 5, assisted dying allows for a support end of life and is a pledge of fraternity and solidarity. It's a chosen moment and a supported moment. Legalizing assisted dying could transform our relation with death, because by organizing one's own departure, the grief of loved ones could be experienced differently and better accepted. This would also prevent violent suicides, and as a deputy said, it offers a supportive death instead of a solitary one. Sorry.
Okay, thank you. So the Citizen Convention was very clear. A lot of these citizen consultations really speak in favor of assisted dying, and this is something where the legal frameworks just have not caught up yet. We are unfortunately really running low on time. I'd like to let one more speaker speak. I saw a hand in the back, and then we will go to Giovanna to close us. Go ahead, please state your name and affiliation.
Thank you. So, Rosa Castro. My affiliation is with the European Rare Disease Association, but we don't have a fully fledged position on this issue, so I'll just... A question from my personal perspective, and also because I'm working now with people living with rare diseases, and many of the people living with rare diseases actually are diagnosed, or the disease starts when they are children, basically, in the first year. So I wonder if you have further ideas, because when we talk about that, it's a bit different culturally, and for children than for older people. Of course, many of the issues remain, but secondly, if you have a chance, because many of you reference family. Family is really important because, especially for the children, of course, some of these decisions, the children are not going to be able to handle them, but it's the family, the relatives. But it's the same also with dementia. I'm a child of a person who died with dementia, and like the burden on the family, on where the person dies, how it dies, it's really completely different. So, sometimes the relatives need to send the person to the place where they have. If it's a hospital right now because there's no option, how the family plays in all of this, autonomy of their own individual. Thank you.
Go ahead, Libby.
I think you raised a really key point, and it was something I really wanted to try and make sure that we gave real justice to. And with all end-of-life care, palliative care, terminal conditions, whether it's in childhood or adulthood, we can kind of imagine like a triangle. You need specialist pet care, but that's the minority at the top. And then you need really good generalist care, like we described, how it's integrated across all health systems, across the response. But really good services are not going to equate to good end-of-life experiences on their own. Of course, you need pain relief, you need diagnostic stuff, but actually it's that baseline of family, community, relational support. And that's where death literacy comes in, because people often don't know where to start. They don't have enough knowledge and knowing how to care. And informal care is the burden of how much economically they're contributing to countries, so much unpaid labour. And we did a survey in the UK recently to discuss people who had been bereaved, and a large proportion of family caregivers of the person that had died that they were caring for said they would never do it again, because there just isn't that infrastructure. And so I think absolutely both kind of caring for that unit when people are dying, but also into bereavement is enormous, and really it's the solid basis of which all care is based, and will increasingly become the oldest old looking after the oldest old if we're looking at the demographic changes. And I think a term, rather than looking at workforce, which is looking at the professionals, multidisciplinary they may be, for people at the end of life, actually the care force, and that's a term that is used by an academic in London, which I really like. So it's actually looking at informal carers, families, healthcare professionals, social care professionals. That's the entirety that we'll need to have ready and responsive to manage these complex issues, because it's not only in the home, even if it's a clinical care, actually it's that much broader level that we need a response to.
I spoke too much. So many of those services, in fact, are not medical services. They're peer-to-peer support services. They're creating the platform to speak to people who understand your experience, who can share their own. It's just this sense of getting to the right information, feeling understood, having the emotional support. It doesn't change the outcome, but it changes how we experience the process and the journey. So maybe this is one message that I would like to leave the conversation on, Nick, also coming to your provocative question, is that there's a lot we agree on, and there's a lot that is not controversial in this field. There is avoidable suffering that we can end now, and we should. There's no question about that. We can help families. We can open the discussion so that no one is left alone with this burden, and that in itself is a huge support. These are things that no legislation needs to give us, and that we can start implementing already now. And building on this consensus, hopefully, we can make progress towards the more thorny issues, which are just as important, so not to take anything away from that. Thank you.
Thanks, Stefania. So really it starts with removing the taboo from death and having more death literacy, really. So I will end there and hand over to Giovanna, my co-host, to close us, please.
Okay. Thank you very much. Well, I will end where I began. End-of-life care, it's not a niche. End-of-life care, it's a human, juridical, democratic issue. And if we are able to get laws and policies which will permit us to offer a timely, a respectful, informed, a participatory support, then we will be able not only to improve the end-of-life care, but to strengthen the huge health system. So this is a sort of a playground. End-of-life care can be a playground to revolutionize the whole health system. Thank you.